Hello, my name is John Pandolfino, and I'm a professor of medicine at the Feinberg School of Medicine, Northwestern University, and chief of the Division of Gastroenterology and Hepatology at Northwestern Medicine, Northwestern Memorial Hospital. And it's really my pleasure today to talk to you about a physician introduction to heartburn and reflux, and really what you can glean from how we approach patients who present with substernal burning in the chest, which is heartburn, and of course reflux and the various symptoms and complications that can occur with reflux. Now, the definition of GERD is considered to be a condition where you develop troublesome symptoms or complications related to reflux of gastric juice from the stomach into the esophagus and the throat. And this can actually lead to a whole heterogeneous symptom and complication profile, as you can see from this particular slide. You can present with the classic symptoms like heartburn, regurgitation, chest pain, but you could also have these other complaints like cough, laryngitis, pulmonary fibrosis, a sore throat. And then, of course, there are the extreme complications, inflammation and esophagitis, stricture, Barrett's esophagus, which is a premalignant condition, and cancer. And when you look at this slide, what I really want you to take away from this is that it would be illogical to think that we would work people up and treat people the same regardless of what the symptoms are. We would not treat everybody. It's not one size fits all, because there are different types of disease presentations. So I'm not going to treat the patient with cough the same way I might treat the patient with heartburn. So it's just something to keep in the back of your mind. Well, what is the mechanism that drives GERD? Well, we know that we are focused on gastric acid and the gastric juice, and certainly that is an important component of this. But it is important to realize that the gastroesophageal reflux disease pathogenesis is not related to people having too much acid or making too much acid. In fact, if you look at normal people and GERD patients, they make about the same acid. There are some hypersecretory diseases, but for the most part, they have similar gastric acid profiles. Really, what differentiates GERD patients from people who don't have GERD is how much of that gastric juice moves up into the esophagus and the throat. And really, the things that promote that are obesity, delayed gastric emptying, increased volume, and these physiologic events that happen at the lower esophageal sphincter, which is really part of the protective barrier preventing reflux. And then, of course, once you do reflux, there are other things that help you or protect you, like saliva production and motility in the esophagus, moving the bolus and the liquid down back into the stomach. And then, of course, hiatus hernia is another important part, because this really causes a disruption of that anti-reflux protective barrier. Now, as I mentioned, though, even though GERD is not a disease of abnormal amounts of acid in the stomach, the target of our PPI, or proton pump inhibitor therapy, is really focused as a compensatory treatment and not curative. Really, what we do is we just reduce the acidity of the gastric juice so that when you actually have it in your esophagus, it's not as irritating or noxious. The problem with that is that a lot of people do fail proton pump inhibitors. And the reason why they fail the proton pump inhibitors is that maybe their symptoms are not related so much to the acid as it is to the reflux of the gastric juice. Because even if you reduce the acidity of the gastric juice, the refluxate is still pretty nasty, and it certainly can still injure the throat and the lungs. The other reason why people may fail PPIs is that they actually don't have reflux. And it's really important for us to think about this, because many people come in with heartburn or chest pain, and they actually have a completely different disease state. So in the back of our mind, when people are not getting better on good, effective PPI therapy, we have to think that maybe we're barking up the wrong tree. Now, GERD can injure the esophagus, as we saw on that slide on the definition. You can see it can have various degrees. So there can be some mild injury, moderate injury, and severe, where you see these deep ulcerations all around the end of the esophagus. And then, as we mentioned, Barrett's esophagus, where although it is a premalignant lesion, the risk of cancer is low, but you really need to make sure that you follow with your doctor. Because if we diagnose Barrett's esophagus, you're not going to die of esophageal cancer, because we're going to keep an eye on you, and we're going to do surveillance endoscopy. If we ever see anything that's bad, we're going to take care of it. So really important to remember that even if you get that diagnosis, don't be disheartened, because we can really survey you and protect you from getting esophageal cancer. So what are the key messages around this? Well, I think some of the key messages here is that GERD can be associated with a lot of symptoms, but heartburn and regurgitation are usually the most common. But we have to remember that reflux can be made worse by a lot of things like trigger foods, weight gain, bad anatomy, and physiology. But with that being said, we can actually treat these particular problems by focusing on some of these lifestyle modifications that will reduce the triggers by reducing trigger foods, reduce the gradient in terms of weight gain, and address some of the issues with bad anatomy and physiology with maybe how we're positioned when we're sleeping and how we're eating. And that's really where we focus. The treatment is focused on the problems that are driving reflux. So we'll modify diet and encourage weight loss. We'll look at medical therapy to suppress or buffer acid. Antacids and H2 blockers, which are famotidine and ranitidine, are very effective on-demand therapies. So usually for people with mild disease, pretty erratic symptoms, maybe less than once or twice a week, those patients can get away with on-demand therapy. But if you're having symptoms every day or more than 3 times a week, it's probably reasonable to take something like a proton pump inhibitor, which is a medicine that actually can suppress acid for the entire day. And you take it once a day and it's very effective. Now, there are certainly some more aggressive approaches that would require surgery and endoscopy that could effectively treat the anti-reflux barrier and prevent you from getting reflux, where you can maybe stop your proton pump inhibitors. But as I mentioned, sometimes reflux symptoms may be caused by something other than GERD, and you should definitely see your healthcare provider if these medications or medical therapies are not working. Now, as I mentioned, antacids buffer acid in the stomach. They're predominantly on demand, just like H2 blockers. They can suppress acid and work quickly, but they're not as strong as proton pump inhibitors. So I like to use antacids for my patients who have, maybe a little bit of reflux after a dietary indiscretion. H2 blockers, which suppress acid, they don't just buffer acid like antacids, a little bit stronger than antacids. I use for people who probably have a little bit more severe symptoms. They know when they eat late, they're going to have symptoms. That's another on-demand medicine that I'll use. But if someone has pretty significant disease, that's where I use the proton pump inhibitors, which are omeprazole, lansoprazole, pantoprazole, rabeprazole, dexlansoprazole, and esomeprazole. So what are proton pump inhibitors? Well, they're exactly what they say they are. They block the proton pump in the parietal cell. The parietal cell is the cell in the stomach that makes acid. And when it is activated, the proton pump can actually block that. Now, this is a little bit of a simplification of the slide because you really need to have that actual proton pump in your system about 30 to 60 minutes before it can actually block the acid pump. And it actually has to come in through the parietal cell. So once again, a very important component of this is the timing with meals. And how do they compare with H2 blockers? Well, certainly if you look at this graph, the purple color representing the H2 blockers and the yellow and the gray color representing PPIs or proton pump inhibitors, you can see that the relapse of esophagitis, meaning the inflammation, is much lower in the patients who are on the proton pump inhibitors, whether they're using a healing dose or a maintenance dose. Now, in terms of our algorithm on how we approach this, well, if we see people who are failing compliant PPI therapy, these are the patients that we do refer for further evaluation. That being said, though, we got to realize that there is a difference in the potency of some of the PPIs. So some PPIs are stronger than the others. And this is the actual hierarchy. So pantoprazole at 20 or 40 milligrams is the weakest PPI. So if you're on that particular dose and not responding, you may benefit by going to a higher potency PPI like rabeprazole or esomeprazole. So that is really the point of this particular slide. Now, as I mentioned before, PPIs work best when they're timed with your meal. They need to work or block activated pumps. So patients are instructed to take their PPIs 30 to 60 minutes before meals so it can be absorbed in the small intestine, get delivered through the blood to the parietal cell, and then within the parietal cell, it gets secreted into what we call the canaliculi, where they can actually block the acid pumps. So really important to remember that this particular timing gives you the best bang for your buck when you're trying to suppress acid with reflux disease. Now, there is one combination of omeprazole called GERD that can be taken on an empty stomach at night that can work very similarly to the timing with the meal, because it tricks the stomach into thinking there's a meal because it has a little sodium bicarbonate with it. Now, it's really important too to make sure that patients follow up, or you follow up with your healthcare provider in 4 weeks, because most people will notice an improvement in their symptoms. And if they're not really improving in 4 weeks, you can use that opportunity to kind of stratify or augment them in terms of their PPI dose and try to improve their compliance and adherence to that dose. But once again, we always want you to consult with your healthcare provider if you were thinking of stopping your medications, because stopping your medications can cause complication, especially if you have chronic reflux with severe injury like erosive esophagitis, the kind of Los Angeles C&D that we saw on those slides, Barrett's esophagus, and certainly strictures. So as I mentioned, the PPIs are very effective, but they do require this delicate interplay between the timing of the meals. But, you know, all of reflux is not related to acid. And remember that even though you might improve the acid level or reduce the acid level in the gastric refluxate, this gastric refluxate still has bile and it still has digestive enzymes, and that can still injure the esophagus. Now, PPIs, although they're effective medicines, do have some things we need to consider: side effects and reactions, theoretical consequences of acid inhibition, and some drug-drug interactions, and this is some of them. The most common side effects and reactions with PPIs are headache and diarrhea, but you can pretty much see anything. And if someone has a distinct symptom after they start a PPI and it goes away when they stop their PPI, then it's probably a side effect of the medicine. There are some theoretical consequences of acid inhibition that are related to potentially changing the pH in the GI tract that may lead to specific problems. And we'll talk a little bit more about this as we walk through the PPI safety issues. And then, of course, there's some drug-drug interactions where your doctor will probably make sure that you either change your medicine or alter your dosage of dilantin, warfarin, diazepam, and clopidogrel. So once again, I think your doctor is going to be keyed in on that. Now, that being said, as I mentioned, there is a lot of anxiety regarding PPI use in the lay press, and we believe that the risk-benefit ratio is in favor of PPI therapy in patients with GERD complications, and those who have GERD documented who are unable to stop PPI therapy to continued GERD symptoms or the risk of GI bleeding. Now, PPI therapy has been associated with a risk of C. difficile or Clostridium difficile colitis, and patients should be advised. So if you do develop diarrhea, you certainly should think about this and talk to your doctor about that. PPI therapy does not need to be altered, though, in certain other indications, like people with osteoporosis or even people on some medications like clopidogrel. Once again, talking with your doctor. But in the end, long-term PPI use is considered safe, and the risks of these adverse events that are theoretical in nature and really only found in retrospective, poorly done studies, such as dementia, chronic kidney disease, bone disease, cardiovascular disease, gastrointestinal cancer, and nutrition or nutrient deficiencies, have really not been proven. And once again, we think that the risk-benefit ratio in the right patients is really highly in favor of continuing the PPI. Now, in the end, when we discuss PPI safety, we still have to realize that lifestyle modifications to reduce PPI requirement is still very important, especially in patients with uncomplicated GERD, because our ultimate goal is to get you on the lowest effective dose of medication. And these recommendations would include weight loss for patients who are overweight, head of the bed elevation and avoidance of meals 2 to 3 hours prior to bedtime in people with nocturnal symptoms, and then, of course, smoking cessation, because this is something that we should be doing for everybody. But that being said, smoking can make reflux worse, and we should look for that. And then, of course, avoidance of excess intake of caffeine, fatty foods, large meals, and acidic foods that trigger your reflux. I will tell you that I do not expect all of my patients to avoid all of these particular foods, because I don't want to destroy their quality of life by making them too focused on all the foods that can cause reflux, and they really only target the actual foods that trigger their symptoms. So in the end, this is a very global approach to reflux, focused primarily on our medical approach and then the potential utilization and issues with utilization of PPIs, and how you can make yourself and self-manage reflux throughout your life. So thank you very much for your attention, and I hope you have a healthy meal without reflux by using these particular hints and facts that I've provided. Thank you.